Good morning, Clara, Mateo. Thank you so much for having me. Thanks to Issachas for putting on this great session, and especially to all of my friends who are speaking. I eagerly look forward to learning from you. So we're going to talk a little bit about lateral instability and repair, and special thanks to Greg for setting this up so well to succeed. Conflicts. So we know, and he's kind of covered this, so I'm going to go fairly quickly. Lateral instability is actually more common than medial instability, and it has a very complicated nature. Greg showed what happens with acute elbow dislocation. So what we want to show you here, if you look to the player circled and kind of the center of the screen, we'll repeat this and you'll see his elbow come down, hyperextend, and come apart. So what does that look like when it happens? Well, I agree with the global theory of instability. I do think it starts on the medial side. It's just that the medial ligament tends to heal. And if you look to the left of your screen marked by the arrows, you see this tremendous avulsion of the entire lateral complex. But this is not all that happens. Everything comes apart. And it looks pretty bad. Greg showed this. This is one of the tests that we do. My best test in the clinic is to flex the elbow to about 100 degrees and then supinate it and palpate with your thumb the radial head starting to move against you. Let's move forward. Oh. And so initial management can be braces or sleeves. We usually get an x-ray early. When you see something like you see here where the ligament's completely avulsed, this is going to have to be fixed. And so an MR arthrogram may be your best test. And our indications for surgery, of course, are pain, functional impairment. And then to arthroscope these patients, you really need to have familiarity with the arthroscopic and open anatomy, because if it's not going well, you have a problem. So here's an acute elbow dislocation. You can see the damage across the anterior capsule, across the brachialis. There's nothing attached on this lateral side as we look around the corner. You should never see this. Again, all the damage, it circles the entire elbow. And I would agree that I think it starts medially. I learned a lot from Sean, but this kind of instability after a dislocation, you wonder how anybody could ever heal anything without surgery when you have this kind of a problem. So it's kind of hard to tell here unless you're there, but this right here, you're looking at the ulnohumeral articulation, and these two arrows are pointing to the proximal end of the entire radial ligament complex that's not only pulled off the overlying humerus, but flipped into the joint. And so you have to go dig this out when you do one of these cases. And so this is us putting an anchor into the humerus in preparation for passing the stitches. But you can see as after we've cleaned it out, you can see this entire avulsion edge, some bony fragments with it. So you really get good healing when you repair these in this case. Greg talked to this a little bit about the abnormal shifting of the humeral head, of the radial head on the capitellum, the bare spot, the exposed entire radial head due to this laxity. To fix this is actually fairly simple. So there's the radial head below. Our arthroscope is in a proximal posterolateral portal looking down the corner. We're cleaning off the origin site of the radial ulnohumeral ligament. So that lets us not only see this area, clean it off, and they'll give us a spot to put an anchor in. So here's the radial head below. Here's the capitellum kind of to your right top. And then we go ahead and we have this, and then it's very simple to establish a straight lateral portal. Here you see the radial head shifting, the ligament pulling away with it. So this is when you're examining it, this is what you're trying to find, and this is what we need to fix. Fixing it can involve this central bone piece. We showed you a more gross specimen, but here's this fragment of bone. So when you get an x-ray and you see that fragment of bone in the center, remember that your lateral ligament complex is attached to this. This is not loose body removal. This has to be a repair, open or arthroscopic, because you should not, as Dr. Bain told us, be looking across the ulnohumeral joint here so easily unless there's a concomitant global instability. So arthroscopic repair can do it. If we can see it, we can fix it. We can stabilize these elbows. Again, here's an acute one. This was a terrible triad. We did arthroscopically. Here's the radial head. You can see the fracture. We've already fixed it. We've fixed our coronoid. We've stabilized our medial side by doing that. And then as we back up, you can see this entirety of the avulsion off the humerus. And so this is actually fairly simple because this is just pulled right back off, and we put it right back. They're going to heal just fine. And so here's this area. We can skip ahead. You can see us localizing where we're going to place the needle to get it into the spot. You have to have an anchor that's going to sit. Sometimes this bone is very soft, so everybody likes different kinds of anchors. I'm not wedded to any one particular type. And so we'll put our anchor in here. And as it goes in, it's very simple. You'll see your stitches coming out here. The sutures are going to be retrieved in sequence from anterior to all the way around to posterior. So if you look at where our anterolateral portal is to the right of the screen, because I use interchangeable cannulas so I can move the scope as much as I want, our first stitches are way here near this portal, and then they come all the way around. So we'll have at least 6 stitches, maybe more, going all the way around the ligament from anterolateral to posterolateral. Your anterior landmark is your radial nerve, posterior osseous nerve, and you come all the way around to the back without a problem. And so here we are, we're going to pass our stitches. I favor going under the annular ligament when we do this so we can tighten the front of it. You can use any kind of retriever, PDS, whatever it is you want. And what you should see is this entire ligament complex coming back to the humerus. Once you do that, then that's in pretty good shape. And then you do the same thing when you do it with a chronic. Here's PDS stitches passing across it, and then our sutures, which will come around. If we're going to do a graft, and we'll show you an outside picture of that in a second, we'll put it down to the ulna and then pass one limb under the annular ligament here using a lead stitch and one over it, and then tighten it up to the isometric point. So rather than do what you see here, we'll put the graft down through a percutaneous incision here, pass one limb under, one limb over, and then fix it here with another anchor. And this is what that looks like. Puncture here, and here's the graft coming across. It was a big graft, large graft for this young lady. Postoperatively, we splint them for a week and let the elbow settle down, and then we start short arc of motion. It braces more to protect the patient from outside activities. And then usually we have a return to full activity at 4 months. But for the acute elbow dislocations, we've had folks back on the playing field as quickly as 2.5 weeks in a brace, protecting it because they felt so much better to have all that cleaned out of their elbow. We wrote this up with Mike O'Brien and Lee Murphy a few years ago. We did 14 patients, all had reasons to do them acutely. And what we found was that they returned to play 2.2 weeks in a brace, and they healed unbelievably quickly because the biggest complication is stiffness, and they maintained this success rate at 2 years. We also looked at a series of posterolaterals that we published, and then an old series that we did mixed open and arthroscopic. And clearly, if you can do it arthroscopically, it's better, but it may mean that you just have a better patient and better ligaments to work with. So in summary, most lateral instability can be managed by arthroscopic techniques. It's an evolutionary step in what we're doing, but those ligaments are pretty much always present if you look for them, as Dr. Bain showed us a few minutes ago. If you have elite athletes, I would strongly urge you to consider early reconstruction or repair. I think that provides a better outcome. And poor tissue quality, especially in revision cases, people that have had surgery before, you may require grafting, but it's becoming more and more rare for me. So I'm a big advocate of repair of these lesions. Thank you very much. And thank you again to Issachos for allowing me to be a part of this session.